we're going to move on to our next session on glioma neuron circuitry. First, I just wanted to thank and congratulate Tawfiq and Homera and the whole team for putting on this incredible symposium. I'm Farshad Nassi, I'm a brain tumor neurosurgeon, and I've been absolutely blown away by the work that you guys have presented here. My lab really focuses on genetics and epigenetics, and so you have all made me feel like I have a very thin layer 2, layer 3 cortex with small neurons that have very slow action potential, so thank you very much. We'll move on to our next two speakers, and I'd like to invite Professor Lucy Palmer to come speak, and she'll be speaking to us on glioma, and how brain cancers actually influence neurons. Thanks very much.
Great. Well, first of all, just like to thank the organisers for inviting me to come and give this talk. It's always a great pleasure to present the work that's done in my lab. So today I'll be talking about some work that we're doing, looking at the neuroscience of brain cancer, where we perform electrophysiological recordings from human neurons. And a lot of this work is actually in collaboration with neurosurgeons. So just across the road, in particular, Kate Drummond, she's the Director of Neurosurgery at the Royal Melbourne Hospital, and Heidi McAlpine is a surgeon trainee who did her PhD in my lab, which is very handy, and really pioneered a lot of the work that we did and still ongoing today. And something that's really handy as well is the location of our lab in respect to where the operating room is. So we're here at the Florey Institute, and we literally run across the road, collect the samples, and then run back to the lab to perform experiments. Okay, so why study brain cancer? Brain cancer, it's a devastating diagnosis. Survival rates are barely changed in 30 years. 80% of patients diagnosed with cancer will die within 5 years. And it kills more people under 40, excuse me, than any other cancer. And currently, there is no cure. And standard treatment has changed minimally in the past 20 years, and all started with the C.E.T.S protocol that was published in 2005, which essentially starts with diagnosis, and then you have resection, and this is where we get our samples from, and then patients undergo radiotherapy and chemotherapy. But in 20 years, there has been some changes, and a lot of clinical trials are really trying to advance treatment for patients, but they're really, this has really struck me in the sense that there's really been no change to the treatment of patients in a long time, despite a lot of research. And so brain cancer survival rates has really lagged behind other cancers. So you can see brain cancer here, glioblastoma is the most aggressive form of cancer, and it occurs in about 50% of all patients. And it's down here at less than 10% of all patients will survive for greater than 5 years, compared to, let's say, for example, breast cancer, which used to have terrible survival rates, but with lots of research and understanding has now increased their survival rates. Okay, so we study glioma, which is primary brain cancers. This is opposed to metastases that are formed, that go up into the brain from other cancers that are formed within the body. And they can occur anywhere in the brain, and this is where we get our samples from. So largely from the frontal lobe, parietal lobe, and the temporal lobe, but we also get samples from other regions of the brain as well. Okay, so I kind of just said some devastating statistics that really has struck me over the years that we've been researching brain cancer. So why is it so difficult to treat? There's multiple reasons, and I'll just highlight 3 today, is that it's actually really highly dynamic. So within a tumour, there's many different types of cancer cells, and I won't go into detail, but there's all these different types that have started from different progenitor cells, and they can also flip across. So it's not like you can have one target that then targets, the cancer cell in the brain, and therefore you can target it and have better therapies. Also, that was mentioned before, is that glioma actually infiltrates heavily into the brain. So here's just an image here of a tumour mass. and then you have the cancer cells, the glioma cells from within this tumour mass. Something that's an important zone is the leading edge, and you have cancer cells right up there. But you also have what we call scout cells, and these are cells that can really infiltrate into the brain, into the basically into the brain matrix. So when the surgeons come and they'll remove the tumour mass, they'll remove a little section on the outside as well, but then you are still left with some cancer cells that have just gone on their way throughout the brain. And something that was kind of first realised in 2019 by a couple of studies, and Sean actually contributed to that, he's been speaking next, was that glioma not only infiltrates into the brain, but it also integrates into neural networks, and that neurons within the brain form synapses with glioma cells, forming something called the neuron-glioma synapse. So here, and these are bona fide synapses. So these are synapses that, neuroscientists that we're used to seeing, where you have the vesicles and then the almost the postsynaptic density onto the tumour microtube, and just, it's a synapse that acts like any other synapse within the brain. Okay, so this is where we kind of came in and started to do our research, where we really wanted to understand brain cancer, basically from a neuroscience perspective and from the perspective of the brain, to ask how does the brain influence brain cancer, and vice versa as well. Okay, so we just performed patch clamp electrophysiology. So basically, as I said, that we're informed of a surgery taking place. We literally, this is Hefe, a postdoc in the lab, she literally runs across the road with her little ice box, collects the sample, comes back into the lab, slices it into 300 micron thick sections, and then is performing patch clamp recordings, basically after all the protocol of cooling it down and heating up, after about 30 minutes of being from the operating theatre. Okay. So we asked whether brain cancer influences neuron excitability. So something about brain cancers, there's many different types. You've got the astrocytoma, oligodendroglioma, and glioblastoma. And they can all be categorised according to their aggressiveness from a WHO grades from 1 to 4. And this is basically dictates their survival. So basically the grade 4, or glioblastoma, the most common, about 50% of patients, have the worst prognosis. It's the most aggressive type of cancer, and it progresses down here. So what we did is that we wanted to kind of separate our samples into the aggressiveness of the samples that we were getting, whether they were from low-grade glioma. We don't often get grade 1 because they don't perform surgeries on them often, but basically grade 2 in the low grade, and then in the more high grade, more aggressive gliomas. And here's just a summary of the types of cancers that we were recording from. Okay, so first of all, to ask whether the cancer aggressiveness or the different grades actually influence neuron excitability, we recorded mostly from layer 2-3 pyramidal neurons, some layer 5 pyramidal neurons from samples received from patients with either high grade or low grade glioma. We did step pulses, evoked action potentials, and then kind of looked at the characteristics of the firing rates and also of the action potentials. And what we saw was that in the neurons from high-grade tissue, they had higher firing rates in the IV curve here. So basically, they were able to fire faster, and this is shown in the rear base, which is significantly decreased from neurons that were recorded within low-grade tissue. We also looked at the action potential waveform. So here you can just see an overlay of action potential from low-grade glioma and high-grade glioma. And if we look at the amplitude as well as the half-width, we can see that the high-grade glioma, or cells within the high-grade glioma, have a decreased amplitude and the half width is small. And this, I don't know, I looked at this and it kind of was a little bit reflective of the difference between pyramidal cells and interneurons, in the sense that interneurons also have the decreased action potential amplitude and width to enable them to fire faster. So the waveform of the action potentials in the cells from the different cancers are significantly different. Okay, so overall, we were able to conclude that neurons in high-grade glioma basically are more excitable. They can fire faster firing rates, and they also have action potentials that seem to be conducive to firing at these faster rates. So within this study, we have a lot of information, or not a lot, but we have information about the patients, including the age, the medication they're on, whether they suffer from anxiety, depression, epilepsy, whether they present with seizures, the gender, treatment that they were on, the hemisphere that the experiments performed from the lobes, the layer. As I said, we recorded from layer 2, 3 and layer 5. Whether it was an awake surgery or anaesthetised, whether they underwent chemotherapy and or radiotherapy. And overall, we saw no significant influence of these different patient characteristics with the results we see. And all the stats always take this into account too with the mixed effect model. Okay, so far, what I've showed you is that you have neurons, and in high-grade glioma, they have increased firing rate, decreased action potential amplitude, and action potential width. But as I said at the start, we now know that the surrounding matrix, the neurons within the brain, actually perform these synapses with glioma cells. So we next ask, well, what about glioma cells? Are they different in the different types of brain cancer? So we performed patch clamp recordings from the glioma cells. So here's just an image of the brain, and so we either performed them from within the cortical tissue, so whenever we got a more cortex-based resection from the surgeries, or actually within the dense tumour. And then we always filled the glioma cells with a fluorescent marker, so we're able to reconstruct their morphology afterwards. Okay. And what we saw was that in our recordings, the glioma cells have really diverse morphologies. And we're looking into this more now, but we didn't really see a strong correlation with the location where we recorded from the glioma cells, or the grade, or and the presence of, just say, a long microtubule or more stumpy processes coming from the glioma cells. Okay, but what we did find was that glioma cells themselves have active voltages. So here we just, we patch onto the glioma cells, and then how we described it, as Heidi always described it, is that their membrane potential was wild. So you put in these current steps, and you're easily able to see, and you can see here that would be, straight line, and then at a certain threshold, you get these wild deflections, active voltage events. And we only ever saw these on these glioma cells, and when we recorded from non-glioma, non-neuronal cells in the vicinity too, which no doubt are glia cells, which had a very characteristic, you input the current step and they just went up in the membrane, no active conductances. There was significant difference in kind of the wildness, or I guess the more scientific term is the variance of the membrane potential in these glioma cells. What we also saw was in a subset of glioma cells, 10 to 20%, they had these what we called spikelets. So these were TTX sensitive little spikes at the start here, and they were quite large. They were about 30 millivolts in amplitude. So importantly, glioma cells have active voltage. We looked to see whether there was a difference between the aggressiveness of the cancer, i.e. high grade versus low grade, in the variance here, and also in the spikelets amplitude, and there was no significant difference. So irrespective of the aggressiveness of the glioma, the cancer cells themselves did have these active conductances. Okay, so we next wanted to look at the synaptic input of these cells. So we either recorded the spontaneous synaptic input, shown here, patch onto gloma cell, and then just record whether they have any spontaneous activity. We also evoked activity just by putting a stimulating pipette up close to the gloma cell, and then we're able to evoke some synaptic input. So we're able to see that these gloma cells actually do receive synaptic input. But something that was actually really interesting was that the synaptic input parameters actually changed according to the cancer of origin. So in high-grade gloma, the peak amplitude of the synaptic input was actually greater than gloma cells from within low-grade glomas, and the frequency was actually greater. Okay, so we can say from this that gloma cells have increased excitability when they're within high-grade gloma. Okay, so we can see that there's increased neural excitability in the high-grade gloma. We wanted to know, what does this actually mean? And also the increase in synaptic activity. And can this actually drive the gloma proliferation? In order to address this, we put slices from, actually here it's high-grade glioblastoma, into 4AP to increase the neural activity. We did this for 6 hours, but we also bathed it for 3 hours, saw similar results. And then we did just immunohistochemistry using Ki-67, which is a cellular marker of mitosis and proliferation, to see whether in the presence of 4AP, so here we've increased the neural activity in the surrounding tissue, whether that causes a greater amount of Ki-67, i.e. More proliferation, than in ACSF, so a control. And we also had another control where we used 4AP plus TTX and the TTX to actually block any neural activity that was ongoing. And what we saw, actually, when we compared it to either of our two controls, so we saw a significantly increased odds ratio when we increased the neural activity surrounding in the slices. And yeah, it was blocked. So what this tells us is that increased neural activity can lead to greater gloma proliferation. Okay, so the take-home message of this study was basically you have neurons, and in high-grade gloma, they've got increased excitability. It leads to greater synaptic activity in the gloma cells themselves, which then goes on to have greater proliferation, or can cause cancer proliferation. Okay. So what are we doing now? So we're doing a lot, and as we all know, that the brain consists of many different cell types. We're not going to probe all of the cell types, but we're really interested in interneurons and the effect actually of cancer and the different grades of cancer on interneurons and their capabilities. We know we're kind of trying to understand how cancer affects the entire microcircuit, the entire network actually, and we're doing this at the moment, cell-by-cell basis, but we're really trying to understand network activity, to understand then how that truly affects brain activity. And in particular, we focused on fast spiking basket cells, PV positive. And the reason for this actually is when we started doing a lot of immunohistochemical statins, we were just able to see literally by eye that the densities of PV interneurons really was different between the samples that were received from low-grade gloma and the samples that we received from high-grade gloma. And this is just a summary of that observation, basically, and you can kind of see it here in these examples where in high-grade gloma you have just a lot lower density of interneurons, of these PV interneurons than in low-grade, sorry. Okay, so we've done a lot, and this is just a snapshot on what we've been looking at. So we're patching onto PV interneurons here. You can see PV with the PV staining. We're reconstructing their morphology. We're looking at their characteristics, their firing characteristics, according to the patient's diagnosis. And what we see, and this is just a little snapshot, but we see that there are differences. We see that the interneurons within high-grade glioma have a higher action potential threshold. In other words, they're harder to make fire. The action potential width appears to be the same, and most other parameters appear to be the same. Okay, so as I said, we're trying to really understand the microcircuitry and how that's affected by glioma. At the moment, what we can see is that PV interneurons appear to have decreased excitability. Pyramidal neurons appear to have increased excitability in the more aggressive types of the cancer. And you can imagine when they work together in a very simplistic way that PV, if you decrease their activity, that means that you probably have an excitation inhibition imbalance in the cortex in brain cancer. So overall, what we see is that this kind of causes glioma growth. So increase the neural activity, you get more glioma growth, more neural activity, glioma growth, and and it's a vicious cycle. And we're really trying to understand this cycle in order to, I don't know, somewhere be able to put a stop on it or at least slow it down. Okay, with that, just definitely like to thank particular Kate and Heidi, who are really spearheading and have taught me a lot. And then also my lab and Hefe, who did the interneuron work that I showed you. And thank you.
Okay, we have time for a question.
Thank you so much. Great talk. It's really amazing that you got the recordings of the glioma cells to work. My question is a bit of a technical question. So what is the intracellular solution that you use for these EPC recordings in the glioma cells? Because I know that there's some data that also suggests that there's inhibitory synapses onto glioma cells that act as depolarizing synapses because of the chloride in the glioma cells. So that would be my one question. And then the second question, when I saw your paper, I was really surprised by the time scale for the 4AP experiments and then the proliferation. Do you have some idea how the activity in your preparation changes due to the 4AP, like what concentration you use? Do you have baseline firing rates and then an increase? Because, I mean, if we think about this timescale of 6 hours and relate that to the clinical situation, that would be crazy, right? I mean, yeah.
Yeah. Okay. First of all, your first question, this is something we're kind of dabbling with as well. So at the moment, the intracellular was the same as the intracellular we use for any recordings, actually. And we use the same for the glia cells and the glioma cells. So we the same, but we're kind of now trying to look more deeply into that. I didn't have time to show it here, but we also see that there's inhibitory input onto these glioma cells that we record, and we're trying to nut it out. So in our hands, we can see inhibitory input, so the intracellular is still enabling us to see that. The 4AP, I was going to put that data in, but for time I left it out. So we did a lot of kind of control studies where we did record the neural activity. We actually were more, we were worried about the health of the cells after 6 hours of sitting there. And so we recorded at different times in the 4AP, and we saw that at all the time points, so we're able to see that there was an increase in activity. We measured that both by kind of action potentials, but also the amount of synaptic activity that the neurons got. So, and we also saw similar results when we bathed them for 3 hours too. So there was a bit of background work that never made it into the paper. I think a little bit did, but yeah, we were also worried about that.
Hi, thank you for a great talk. So you show that the tumor cells can clearly form postsynaptic structures. Can they, and that are functional? Can they also make presynaptic structures that are functional? Do you know, or
yeah,
maybe they have large dense corpuscles? I don't know.
Yeah, you know, it has never been shown, but I would step away from saying that it's not possible, and that is something that we really want to look into. We haven't yet, but it's because, I don't know, a sneaking suspicion is that they may, but not that we don't have any evidence, but we haven't really looked, but we really want to, and I'm assuming others are as well.
Thanks for the very nice talk. I was intrigued by these variants at the beginning when you recorded. So does it mean that this is sort of channel noise, and then you have very few channels with huge conductance, both depolarization activated? Do you know what they are?
Yeah, so we want to know. So short answer is no, we don't know what's driving it, but we've done a lot of pharmacology as well to try to delve into that. Off the top of my head, it's a bit of a matrix, but yeah, so we don't know, we want to know, and but pharmacology is never that straightforward.
Yeah, maybe it's the same question. I just missed your question, Michele. But so the spikelets that you observed in the tumor cells, was it that question? They're quite broad in their waveform. Do you completely block them with TTX, or do you think there is also a role for calcium signaling? Or
Yeah, exactly. I was just talking to Albert about that yesterday, actually. Yes, so the spikelets are TTX sensitive. Some of them, I should say. So we're able to evoke them under different protocols. And so the ones that are more of the classic thresholded up there, they're definitely TTX sensitive. Some of them are not TTX sensitive though, so it appears as though there might be some that are caused by calcium channels, and that's what I was just kind of alluding to before, the pharmacology. So we always dump in all the drugs to try to really understand the channels and the mechanisms of the cells. It's a mixed bag, but we're trying to tease it out. But at the moment, spikelets, most are TTX sensitive, some are not and appear to be driven by calcium.
thanks.
Great, and we'll do final question.
Thank you. Terrific. I'm wondering off the top of my head, do you think it's possible to culture these slices and then use viral strategies to target the glioma cells?
Yeah, I don't know if that... yes, so that's what we're just starting now, and I've been talking a lot with Ed and Brian's over there, and Jonathan, about doing exactly that. So that's what we want to do in order to get viruses in, to try to have a more, what I was saying, just a more almost controlled approach to really tease out the synaptic activity. We're also using what Albert will be talking about later, the fast-acting viruses, and that's also because we really want to target the synapse and to really probe it using the more modern techniques. There's using the extracellular stimulation. What we've also done is the glutamate and GABAergic puffing, and there's complications associated with that. So yeah, we're onto it.
Well, thank you very much, Dr. Palmer.